All right, we're going to get started. Good morning. I'm Connie Kazri. I'm a member of the Center for Autism Research and Treatment. And this is our first, whatever we call this, CART Distinguished Lecture for this year, 2023. And I'm really happy to introduce Alex Sturm as our first speaker. We have about, I think, 35 people online, and we have about that many maybe in the room. So we're going to have some time for questions. If you're online, please use the Q&A box, and I'll monitor those as we finish up. So Alex is an assistant professor of psychological science at Loyola Marymount University. She graduated college from MIT. She's actually a Californian though. So you went to MIT, then you made your way back to UCLA, where she did her master's and her PhD in human development and psychology here under me. And then she did a postdoc with CART, still in CART, and then with CREST, which is the National Center for Research on Evaluation Standards and Student Testing. So Alex has a lot of expertise in statistical approaches, especially to big data. And she's also a licensed psychologist. And she specializes in autism and ADHD. I think you were the co-developer of ThinkSmart, which is an executive function flexibility intervention as well. So since going to LMU, Alex has focused her research on promoting equity and access for neurodivergent youth and adults across life contexts, including school, the workplace, and healthcare. She was awarded one of our CART grants recently, and I think that's what you're reporting on today. Yeah. So some of her recent work that focuses specifically on how neurodivergent women uniquely experience barriers across life contexts. So we're really happy to have Alex here. I was going to try to tell some, I don't know, embarrassing story, but then I couldn't think of any. But maybe I'll think of them as we go along, and I'll talk about them later. Okay, thank you. And so let's bring up Alex.
All right. Hi, everyone. So today we're going to be talking about autistic women and really centering autistic women specifically around this issue of reproductive health and thinking about how we can shape inclusive science and also think about reproductive health as a site for translational research and what that might look like. Let me know if you can't hear me and I'll just project more. Okay. So before we start, many thanks to the students, interns, and graduated students who've helped with this work, to my collaborators and thought partners. This requires so much interdisciplinary expertise to think about issues of gender with medical issues. So we have neuropsychology, women and gender studies, reproductive endocrinology, autistic self-advocate partners represented here to be able to really create a complete picture of what we're trying to think through. Then, of course, to the research participants who were so open in sharing their experiences, and we'll talk through some of those today. And then, of course, to funding. This work was funded by the CART pilot grant. Connie and Dr. Kazri and Dr. Lord were PIs on the grant, and also with some funding from LMU for research participant payments as well. So our goals here today are to talk about and to demonstrate the areas of a woman's life that are impacted by menstruation and how autism uniquely intersects with experiences during menstruation. By the end, we'll be able to think about how we use women's experiences to guide translational research. So the motivation is really using women and talking about, well, specifically natal girls, how they're talking about the experience to think about the next steps. This is going to be accomplished by talking about results from 3 different research studies. Briefly, a study of autistic women's sensory experiences. That was the motivating study. Then this autistic women's health study, and then a measurement study of autism symptoms among autistic adults, also to complement and to think about areas for insight and a little bit of context. We're going to be reviewing many quotes representing the intensity of personal experiences and to kind of complement some quantitative data. So we'll be seeing that throughout also. A quick note about terms. The studies are going to talk about recruited individuals who were born with a female reproductive system. So that was the language that was used in recruitment. Currently, those individuals hold very diverse gender identities. So we're going to be referring to those individuals, the study participants, as natal girls. So assigned a gender category of, it's a girl when you get that ultrasound picture. First, let's think about our definition of women's health, women's reproductive health. So women's health is defined very broadly. So we have this nice word cloud to depict this issue of women's health and what's encompassed by women's health. When we think about reproductive health, I really liked this definition from the WHO, which was more inclusive, thinking about not only pathology, but also well-being. So reproductive health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, in all matters relating to the reproductive system and to its functions and processes. We also have to, as we approach thinking about reproductive health, issues of gender and how those are layered with this a medical biological process. So when you are presenting with a gender, you're not only presenting in a social environment and getting feedback from that social environment, that feedback is also layered with your internal experience of your gender, including your reproductive health. So what's happening biologically, what's happening with your hormones, what's happening in your body. There are also differences in how bodies interact with the environment, and that also produces different needs, particularly regarding health. So this is one area that we'll talk about. I want to highlight autistic women's health as really an issue of health equity. Autistic women are underserved in research and clinical practice, particularly related to issues of women's health. This includes healthcare access, where autistic women are half as likely as their neurotypical peers to utilize preventative women's health services, and also have the lowest utilization of medical specialties that serve women specifically, so obstetrics and gynecology. This issue of health equity also includes health experiences. So during periods of reproductive transition, including menarche, menstruation, and menopause, autistic women have endorsed experiencing really debilitating physiological and psychological changes, some of which we'll talk about today. There's also discussion of hormone imbalances and increased prevalence of endocrine dysfunction among autistic women that pose additional continuous challenges that adversely impact mental health. So the motivating study that led us into the research about reproductive health was a sensory study of autistic women. So autistic women being interviewed about their sensory experiences and also completing a survey about their sensory experiences. So we asked natal girls about those sensory experiences, and we were surprised to see that issues of women's health emerged. So this originally was a mixed method study of 60 natal girls. Early on in the study, after seeing how often issues of health and women's health related issues were coming up, we added an interview question: how have your food preferences been affected by hormonal shifts, including puberty, the menstrual cycle, birth control, pregnancy, and menopause? And we'll talk through a couple of those quotes. What came through was that health concerns were layered with concerns related to other domains. So it wasn't that we could separate these domains, thinking about health, thinking about sensory symptoms, thinking about autism symptoms, as really separate experiences. Everything was layered and coming together to uniquely shape how a woman, or how in this case, natal girl, was interacting with their world. What was also striking was the scale of the reproductive health problems and the degree medical professionals diminished the reported experiences. So there are a lot of really negative and often traumatic interactions with medical professionals that was also a huge impetus for conducting the study we did. So a couple of quotes from that study. Participants talked a lot about the intensity of their menstruation experiences. So I'll read through, hopefully no children are listening. My cycle is a bitch. I have endometriosis and get super moody around my period when I'm not taking oral birth control, which I don't anymore because it makes me have more migraines. I switched to trying an IUD a couple of years after my endometriosis surgery. Everything is catastrophic during this time to my brain, my body. My mood tanks into horrible depressive episode shutdowns for the littlest reasons, including changes in my schedule, something I wanted to do falling through. On top of that, being in pain just makes me a miserable person. The participants also really highlighted the complexity of the intersection between mental health and reproductive health. So these two quotes really highlighting that. When I was in high school, I struggled with puberty and sensory changes of my body, and it felt out of control. I wanted my prepubescent boy body back, so I tried to starve myself. I did a lot of withholding food up until I had kids. I never used vomiting or pills to get rid of food. Another participant said from about 45 to 48, I went through menopause. Another hormone change mixed with the high doses of anxiety meds and antidepressants I was put on. I did not know much or understand the sensory body hormone changes of menopause. I always had gastro issues, but they became disabling. I couldn't leave the house. I began binging on processed foods and sugar regularly and stayed in the recliner in a numb state. And last one, there were also some positive changes with hormone shifts, really highlighting that this experience was incredibly personalized for each individual. Another participant said, I felt amazing during pregnancy. I exercised, my executive functioning seemed normal, and I felt clear-headed. The constant heaviness in my belly felt like a weighted blanket, a comfort item, very grounding, and excited about becoming a mother. I had 3 miscarriages, 2 live births. So from these experiences, there was one very clear finding among obviously many others. The qualitative experiences of the impact of hormone shifts were incredibly varied. And it was also clear that we know very little because this isn't part of the conversation typically in autism research. So our motivating problem in thinking about the autistic women's reproductive health study was, to date, remarkably few studies have systematically examined the prevalence of reproductive health concerns among autistic natal girls, and no studies have assessed the impact of each condition or probe methods of management used to ameliorate condition impact. So thinking really holistically, what are the symptoms experienced? What is the impact of those symptoms? And how are people trying to resolve and deal and cope with those symptoms during their cycle? So that leads us to the Autistic Women's Health Study, which was partially completed over the last year. We just have initial data in, so this is preliminary results. The methods involve survey data collection about reproductive health and impact, a second component of the study will be following a subset of natal girls during 3 consecutive menstrual cycles and collecting prospective behavioral data and hormone data as well. We have preliminary results on 55 natal girls. There's going to be a second round of data collection that will happen this month through Research Match, so we'll have a target of about 350 surveys. All participants were 18 or older. They were either diagnosed with an autism spectrum disorder or self-identified as a natal girl, and we're also natal girls. So what did we ask participants? We asked participants about both menstruation and menopause. Symptom domains were assessed during or about their experience during these reproductive transitions. Those symptoms were pulled from qualitative studies of reproductive transitions, so both menstruation and menopause, and some from pregnancy as well. We grouped those symptoms into 4 larger categories, so physical health-related symptoms, mood-related symptoms, autism-related symptoms, and then also executive function, as those were the symptoms that were really kind of emerging from those qualitative studies. We also asked open-ended questions about experiences with menstruation and menopause, related symptom management, and also experiences with medical providers, given that we saw such an intense experience and history of experiences with providers. We collected a few other measures, including quality of life, autism symptoms, and also social support. Today, we're just going to be talking about the menstruation data. For each of the symptoms, or for each of the symptoms within each of the symptom areas, we also asked about in the 2 weeks before your period or during menstruation, do you experience any of these symptoms? And then for each symptom, were you impacted in one of 3 domains? And those domains were work, social, or daily living. So let's walk through some preliminary findings. So I included this picture from my son, which he entitled "A Ghost with a Blood and a Monster in It," and coincidentally gave to me a month or two after I had given birth to my second son. So I was like, okay, a little Freudian moment. I don't know what's happening exactly, but it just seems so apt. So a little bit of a spoiler alert content warning. No participants so far are talking about how menstruation is a beautiful and essential part of their reproductive health. And this picture kind of portends the narrative that we'll be hearing today. Obviously, that might change when we collect more data from different individuals, but this is what we're seeing so far. So who are our participants so far? Predominantly Caucasian, Black and African-American natal girls were the second largest category, racial ethnic category. The majority had a 4-year college degree. 73% had a formal autism diagnosis, and on average, they were diagnosed at 28 and a half. The mean age of participants was 37 years. 81% had health insurance, 67.5% were under the care of an OBGYN, and 71% were currently menstruating. I'm so used to pausing and asking for questions because I teach all the time. So like, no, but I think we have to save questions till the end. I know this. Yeah, I know. Write it down. Yeah. So here we are with the menstrual cycle and hormone fluctuation during the menstrual cycle. Featured here are 4 different hormones, some more are at play. So this is LH, FSH, estrogen, and progesterone, where LH and FSH are peaking right around ovulation. Estrogen is peaking before ovulation and again following ovulation. Progesterone is peaking following ovulation. 4 weeks, 28 days is the typical length of the menstrual cycle. Menstrual cycle on average is approximately 5 days, and that occurs at the beginning of the menstrual cycle. On average in our sample, menstruation was about 4.76 days, and the range was 2 to 7 days. In terms of average cycle length, 4 weeks was the most common cycle length, but cycle length ranged from 2 to 6 weeks. 18% of participants said their cycle length varied from month to month. Though we have what seems to be a very stable graph, right, of hormone function, this in fact fluctuates considerably just in the typical population, the general population, I should say. This follicular phase and luteal phase varies widely. Ovulation can happen anywhere from immediately following menstruation and very late into the menstrual cycle as well. So huge amount of fluctuation in hormones, in the timing of hormones in the menstrual cycle across individuals. So as a reminder, we're talking about menstruation. We asked participants in the 2 weeks prior to menstruation or during menstruation, did they experience symptoms in any of the 4 symptom domains, and to what extent was their life impacted in work, social, or daily living? Then we'll also talk about these open-ended questions. So if we overlay some of these symptom areas and some of the themes onto this graph of the timing of menstruation and timing of hormone function or fluctuation, this is what we saw. So the majority of physical symptoms were endorsed during menstruation. So that's when the natal girls who are participating in the study articulated struggling the most with the physical experience of menstruation. That's not to say that other individuals didn't endorse physical changes at other times as well. That was just the bulk. The bulk of cognitive or cognition-related symptoms were endorsed in the week before menstruation. Some 2 weeks before, for some that continued into menstruation as well, but to some extent, cognition-related symptoms were masked by physical symptoms because of their intensity and severity. We also noticed this theme of participants needing to cope throughout the menstrual cycle. So there was a lot of, we'll talk through this, but a lot of planning that needed to happen around the menstrual cycle, consistent coping, people feeling very fatigued by the process of their menstrual cycle because of how much energy it took. And then we also see consequences throughout the menstrual cycle as well, which we'll talk about. So the next slides will be organized generally by these 4 themes. So here are the physical symptoms during menstruation that we asked about: cramping, bloating, change in appetite, tender breasts, weight gain, and constipation. Other physical symptoms emerged also, which included nausea, vomiting, diarrhea were the most prominent, but we hadn't asked about those in the quantitative data. In terms of interpreting what's happening here, the percentages underneath each of the symptoms are the percent of individuals in the sample who endorse the symptom. Each of the bars represent the percent of individuals who indicated that the symptom impacted their work comes first, social functioning second, or daily living comes third. So you can see for physical symptoms, cramping and pain related to cramping was the most impacting experience. And nearly the same percentage of individuals who experienced the symptom or experienced pain and cramping during menstruation also said those symptoms significantly impacted them in their lives. So menstruation related to cramping can be very severe, but there was also a spectrum of pain and controllability that the women discussed in some of the open-ended responses. There were additional significant physical symptoms beyond those from the quantitative questions during the period that were asked as well, which I talked about a little bit, and you'll see here. So let's go through just a snapshot of, I would say, the range of experiences. Some of these sound very intense, and I want to highlight that those are not unusual. So the intensity of the experience was something we saw pretty consistently across the sample. So even though this highlights a range, the majority of the experiences were very, very intense. So one individual said, my pain used to be really extreme during my 30s. I would literally vomit and faint, unable to keep down food or water. But as I aged and also had a huge change in my diet, the pain is not so bad anymore. Another participant described their period as a dull ache in the center of my lower abdomen only on day 1. Another participant said the abdominal pain was the worst, and sometimes I just curl up on the floor with it. No one suggested I use medication for the pain, and no one explained why there was pain, which probably contributed to its intensity. And then finally, the pain would sometimes feel like Wolverine was let loose inside me, or that a stake had been driven through my uterus and out of my anus. I would feel as if I had been shot, shaking and unable to move. The pain always felt greater than a 10, closer to an 11 or 12. Sound and vibrations from heavy footsteps would also make the pain hurt more. So again, intense experiences, and these were not unusual. Okay. There were also a lot of instances where physical symptoms were overlaid with the consequences. So the participants in the study were describing multiple things at one time, being very interrelated. So another participant said, I went through 7 gynecologists from 19 to 40. I went to the ER multiple times and was told to go home, as it was a normal woman's experience. I passed out from anemia regularly. I was prescribed Vioxx, Wellbutrin, Celebrex, gabapentin, and mefenamic acid. Finally, the last gyno I saw listened to me and said I had no quality of life. He said it sounded like I had fibroids as my stomach was so distended. I was finally given a transvaginal ultrasound that showed fibroids and was suspected to also have endometriosis. I got a hysterectomy at 40, and it was the best thing that happened to me. I wish I had gotten it when I was young and asked repeatedly for one. So this is where we start to see kind of the dismissal of medical symptoms coming through. That was also not uncommon. That was a very common experience. So reminder, pulling it together, cramping pain, most common physical symptom that we saw. And next, we're going to think about cognition, which again, as a reminder, most common cognition-related symptoms occurred in the week before menstruation. So first, thinking about emotion and mental health. So symptoms we assessed were irritability, difficulty controlling emotions. People experience more meltdowns, more difficulty recognizing their own emotions, more anxiety, more depression, or more trouble sleeping. These are obviously organized in order of the percent of individuals who endorse the symptom. Controlling emotions and irritability were by far the most common symptoms endorsed. These symptoms are making the greatest impact as well. But you can see all mood-related symptoms were significantly impairing for individuals. So cognition in terms of emotion and mental health really came through as being significantly impairing. If we think about executive function, difficulty staying focused and difficulty with planning, the majority of participants also endorsed increased difficulty in these domains before and during menstruation, with significant impact in other areas of life. And then autism-related symptoms, so sensory sensitivity, sensory overload, less socializing, need for consistent routine, and more stimming, where sensory experiences and sensory overload really, particularly in this area of daily living, came through as the most impacting, most prevalent and most impacting and impairing symptom. So now let's think or hear some about the experiences related to cognition. What came through in the open-ended responses was really the intersection between mood, sensory, executive function, and physical symptoms during the menstrual cycle. So this layering of all of these experiences. A participant said, I began to recognize that if I was suicidally depressed and if it had built up fairly quickly, to consider whether that time of the month was approaching. If so, then I tell myself to wait and confirm that this wasn't my true mood, that my period was making me feel worse. But for a long time, I never made that connection. Another participant said, during the week before my period, I do not have the cognitive bandwidth to manage my emotions, all of which come with physical sensations. So I'm already raw even before outside irritants pop up. The emotions even out during my period, but I'm underslept and already compensating for bloating, the pressure of cramps. Pain management only treats the pain, not the sensation of the uterus squeezing itself around. The sporadic feelings of gushiness in my pants, and when the cup is full, menstrual cup, the constant metallic scent of blood, itchiness in my crotch and thighs at night, in the morning of dried blood particles until I can wash them off. This means there is little left to manage other sensory stimulation. And another, I have found myself to be more sensitive to my environment right before and during my period. Noises, lights, and people bother me more during this time than they normally do. I'm also more prone to getting upset over small things and bothered by things that normally would not. There was also, which popped up a couple of times, an experience of gender identity and sexual orientation during menstruation that varied from when a person was not menstruating. So one participant said, I look and feel more masculine during my period. I have a lot of facial hair and it always comes in full force around my period. All of that is depressing and anxiety inducing. I feel less female and more attracted to women while on my period. Another participant said, having a period has significantly impacted the feelings I have regarding my identity and really all that surrounds being a biological woman. I remember wishing often during my early mid-teen years that I was born a biological male that could just present female, or born without a uterus and things of that nature, which ultimately led me to question my gender identity a lot. I also presented more masculine during this time to fill some of that void. I feel this is notable due to the fact that when I consistently don't have a period, I'm significantly more content with my gender identity. So we see impact of menstruation in so many areas of life beyond which we would really consider. So to summarize some of the themes, the impact of menstrual cycle on mood and sensory symptoms and their interaction was really a prominent theme. Managing mood can be very difficult in the week before menstruation specifically. There was also a big executive function impact, and the specific timing of sensory changes was also important. Changes in sensory perception are occurring predominantly before menstruation. But then we also have a different sensory experience during menstruation, which is just the experience of menstruation in and of itself and how that differs from the day-to-day. So we have sensory changes almost at a cognition level before the period, and then this intense menstruation-related sensory experience that also impacts daily life. The experience of gender and sexual orientation may also be different during menstruation. This just popped up for a few people, but is notable given that our sample here for the preliminary data is only 55. So for those of you who know me, know I can't get through a talk without talking about measurement in some way. So this is my sneak in of measurement in that conversation. So sensory symptoms we know to be an enormous part of an individual's experience with autism. In a recent measurement study of the RADS, we found that 87% of diagnosed and 93.9% of self-identified individuals endorsed a particular RADS item. When I feel overwhelmed by my senses, I have to isolate myself to shut them down. This was one of the 4 most discriminating items on the RADS, meaning the items most able to discriminate between individuals who diagnosed or self-identified as autistic and those who did not. There are other sensory symptoms on the RADS. The difference with this symptom is it also describes impact. So the necessity of isolating in order to regulate. In our sample of 55, only 1 participant did not endorse this particular item. This participant was also one of only a few who did not experience sensory changes with menstruation. The participant said, sensory aspects of autism have always been minimal for me. I dislike certain types of loud noises, particularly people talking or screaming too close to me, and a couple of textures, but it has never been too disruptive to my life. Doesn't get any worse before, during periods that I've noticed. So what does that mean? One thought is that an individual may need to be at a certain threshold for certain symptoms. That could be sensory. It also could be anxiety, depression, to feel a substantial change and impact of the symptom during menstruation. So this also may be true for mood-related symptoms. An individual who experiences no depression may not have a noticeable change in depression symptoms during menstruation. So you may need to be at some threshold level in order for this change with menstruation to feel particularly impairing and impactful. That's not to say that everybody isn't experiencing, anybody who's menstruating isn't necessarily experiencing some level of change. It just might not be at threshold to be noticeable. So now let's think a little bit about coping and some of the themes that emerged with coping. So many different themes, starting with awareness. Awareness was really important in someone's ability to reflect and understand where they were in their menstrual cycle and how that was impacting their daily life was really important to them, having self-compassion as well. So awareness, for example, being aware of why my mood falls helps me sort through my thought processes, sensitivities, and helps manage the world as ending feeling. Knowing why also helps me know that it will pass. Sticking to routines also helps. So this process of being aware and having other supplementary strategies once the person has established awareness of where they are in their menstrual cycle. Self-compassion came up over and over again as being really important. Generally, I am more lenient and forgiving of myself. It does seem like it should be easy to engage self-compassion, but remember, this is a group of individuals, specifically autistic natal girls, individuals who are femme presenting, who are raised as female, tend to be very, very hard on themselves because of repeated negative social feedback. So engaging self-compassion can be very, very difficult, which is why it's so important that it came through in some of the data. A number of participants endorsed using mindfulness. So one person said medication, mindfulness practices, lots of rest. So mindfulness as it ties into awareness and self-compassion. Medication management. For a while, I increased my Prozac by 10 milligrams 2 weeks into my cycle, then would cease the increased 10 milligrams once my period started. This seemed to help. A number of participants also reported taking their birth controls back to back. So they were skipping periods essentially, or using an IUD for the same function. So where you're just not experiencing your period. This was the only participant to endorse purposefully changing a antidepressant medication or SSRI in preparation for the menstrual cycle. Some individuals reported their medications worked differently for them during certain components of their menstrual cycle as well. Social support was also really important. One person said, tell my partner of any unmet needs, including asking him to make comfort food, ask my active child to be active somewhere else, which I really liked. Planning was really important. I tried to schedule and complete challenging tasks for the month in the first week after my period, so I can do less and be kind to myself. So this self-compassion again, before and during my period. I think it's important to zoom out, especially with planning, and realize that this means that individuals are having to plan every day, plan out what their lives are going to look like around their menstrual cycle, which is happening potentially depending on if they're using medication or medical strategies to continue menstruating or not, every month, right? For years and years and years. So there's a constant necessity for management, which people described as being extremely exhausting. And of course, there were a number of individuals who also said they just powered through symptoms. No, I have quite a high pain tolerance. Also, I would never take a day off for that. I don't feel like my all-male bosses would understand. I just power through it. So now we can continue to think about consequences. We've heard consequences throughout some of the narratives already, but there are even more that popped up as if you need additional support for that. But one was interactions with medical professionals and issues with access to services. So participants said, as you can see, I started shrinking font because I was like, I just want to get as much of this information as possible on slides. I spent a decade trying to figure out what was going on with my body and how to help it. I was misdiagnosed as bipolar when the swings were due to imbalanced hormones. Insurance rarely covers a lot for hormone therapies, and most doctors are not well informed of how to treat it properly. I have taken bioidentical progesterone, progesterone cream, progesterone over-the-counter supplements, birth control, IUD with hormones, and NuvaRing. I also did pelvic floor physical therapy, had imaging of my bladder, vagina, and uterus, went through a colonoscopy at 35, and had a laparoscopic robotically assisted hysterectomy at age 36. I think it's also important to highlight, in terms of both coping and consequences, we had a number of people who had had hysterectomies either in their 30s or 40s, and this was not uncommon, and it was always a welcome, appreciated, and anticipated experience. So I think when general population thinks of a woman removing their uterus, it sounds horrific, right? The narrative was very different as it emerged from the autistic women. It was women saying, or natal girls saying, I've been wanting a hysterectomy for years, and finally somebody listened to me, and there was no regret. I have had next to no reproductive health care, even though I'm nearly 34. As an asexual, agender person, I don't feel very comfortable approaching medical services in my rural town, and I can't drive myself to a bigger city. So then we start to think again about issues of access and healthcare access for individuals who are living more remotely and may need more specialized care, but have difficulty accessing due to other limitations. There was also just a lot of difficulty in finding adequate treatment. I reacted unusually to all forms of hormones, naturally or drugs, and even had a life-threatening reaction to a round of medicated IUD that caused ovarian hyperstimulation. My body has just never reacted normally to hormone changes of any kind. Many also reported needing to take time off work or having to schedule around their periods. When my period was really bad about 5 years ago, I'd be unable to eat, drink, walk, or do anything at all for 1 or 2 days of the period. So I'd have to call in sick. My worst period ever involved 3 full days of throwing up every single drop of water or piece of food that I tried to consume. I think it's also important to note that we are seeing the greatest self-reported impact to daily living of those 3 domains, so daily living, work, and social. And because this wasn't an interview study, we weren't able to probe that. But the suspicion based on the open-ended responses is that there's an element of powering through in domains of life where there's an expectation that an individual power through, so work and social, and then everything else or other areas of their life where they're typically taking care of themselves may be more impacted. So their daily life, you're not able to keep all the balls in the air, something has to drop, and where you're not expected to power through is typically where the balls are going to drop. Many, many more consequences that I wasn't able to sneak an extra small font on the slide, but so many. Now, if we start to think about translational research and what do we need to do to further understand different aspects of the autistic experience regarding menstruation, and also health equity, health access, and awareness. So starting point, we need to understand the impact of hormone function on the brain and subsequent effects on mood. Just don't understand that. There's even limited literature on this, especially subsequent impacts on mood from a general population perspective. So there isn't even great necessarily comparison data to understand reference. We also need to identify other biological processes that might mediate or moderate this impact for different individuals, because as you saw coming through on the different narratives that we talked about, everybody's experience is incredibly different, right? Which leads us to suspect that there's, right, a combination of how they're navigating their life and that the impact of that experience, but also what's happening internally. We also need to understand variability in hormone levels across autistic women, and how hormones impact lived experiences. We have that slide, that graph that demonstrates hormone function, or that shows hormone function over, or hormone levels over the menstrual cycle. But we don't know the extent to which this varies, to what extent the heights of those curves vary, the amount of hormones in the body varies, the extent to which hormone function in the body varies. So another really important area for us to think about. Another is to identify treatment approaches that are effective for particular individuals. One thing that was really noticeable is that different individuals had different strategies, right? People had cycled through a bunch of strategies to try and figure out what worked for them over the process of many, many, many years. So there is not going to be a one-size-fits-all approach. This also needs to be based on presenting clinical needs while also considering what's happening with hormones in the body. What is the impact of those hormones, and how does that vary across individuals and across their menstrual cycle? Treatment should have both biological and psychosocial targets. Given the relationship between those two things that we saw through the narratives, those two targets are both really, really important. Provider interactions, right? We need to create greater awareness among medical providers about the reproductive health related experience of autistic women and their unique needs. They're also just naturally, right? We have biases about how individuals think about their bodies and the importance of different body parts. So if you think about your uterus, for example, the idea, as I said before, of taking a uterus out of a woman, it's like you're no longer a woman. Like, what are you going to do? How will you function in this world without your uterus? But the narratives we saw, there was no regret, right? People had done their research. They had thought about the consequences. They knew what they needed to be functioning and successful. And that was one essential component. Next. We also need to create greater awareness among autistic women about hormones, the impact of hormones, and the potential relationship between hormones and autism symptoms and mood. One participant had said this was so interesting and helpful, referencing the survey. Honestly, I hadn't thought about periods as contributing to my sensory and executive function issues, but I can see that relationship. And this came through in several of the other narratives as well. The natal girl saying, it took me a very long time to figure out this relationship. And it took so long because I had nobody talking to me about it. And I thought nobody cared. That narrative came through too. And then we have to make sure this is all very personalized. We learned that every individual's experience of reproductive health is different, and a different constellation of factors are coming together to impact lives. So there is a high degree of personalization that will need to happen, and a high degree of reflexivity and thinking about the individual and their experience and getting information back for them about their experience as well. Perfect, great timing. Okay, so to wrap up, I want to revisit the WHO definition of women's health, saying reproductive health is a state of complete physical, mental, and social well-being and not merely the absence of disease or infirmity in all matters relating to the reproductive system and to its functions and processes. So if we reflect back and think about the individual experience and also the impact of their experiences related to menstruation, it takes up a huge part of an individual's brain and has significant impact to their life. So we need to think about both the pathology, right? But also how do we promote well-being and wellness for this group of individuals? We know autistic women are underserved. We know reproductive health is currently not adequately addressed in research or practice, despite profound implications. Research is going to need to consider subjective experiences to ensure personalization. We want to promote wellness related to women's health, which may be different from minimization of pathology. Great, perfect timing. Okay, thank you.
That was great. Very interesting, very different from what you did when you were here.
Yeah.
I love it. Okay, so we have some questions. I'm going to try to take questions from the people online. There were 50 people online, so that's a lot of people. So,
and then I'll say it again so they can hear me through the microphone. So you'll say the question and then I'll say it again.
Okay,
I'm good.
Great. Yes, but let's take a question from here. Oh, yeah, you can.
Sorry, Shula. Shula's been waiting for like 40 minutes.
I'll let you.
Yeah,
you can handle.
Oh.
Yeah, Sheila, go ahead.
Yes, I'm staying in. Monica's reminding me to stay in the camera. Thank you to my director.
You have to look down because we're seeing like the top of your.
Oh, sorry.
I hardly see your face.
Oh, okay. It's like minute. What are we on? Minute 49. You're like you had a booger the whole time. Thanks.
You'd have little kids.
Yeah.
I think.
Okay, Sheila, yeah.
Great talk. That's really important topic. My question is kind of two parts, both relating to population. So one question is that, or I guess thought process is that these are issues that are understudied as well, not just one. And so I'm wondering if you have any comparison to non-autistic individuals. Yeah. And which it would be interesting to have a better sense of which aspects are specific to autism,
yeah,
and which are just completely understudied,
yeah,
overall.
Yeah.
And then the second part is that even within autism, it appears to have kind of a particular contingent of the autistic population, given that these are all people, the mean age of diagnosis is 28, which is pretty interesting, I thought. So also wondering if you could expand on that and if you think there's anything unique about this population and their responses given that later age.
Yeah, so thinking about like sampling and comparison sampling. So I don't have a comparison sample, and I agree. It's just the issues are understudied overall. So I think that is in terms of thinking about the issues, next steps, right? To have a much larger study based on the like rate of some of the, specific symptoms and specific experiences we were seeing. In order to really sufficiently study conditions, we would need, I think, tens of thousands of people to really have a good understanding of what's happening in the population of autistic individuals, meaning we'll need a similar comparison sample. Obviously, that's very difficult to do. So no comparison sample here. We do know from some survey studies that the rate of dysmenorrhea, for example, so painful periods, is around like 90% in the autistic population and is nowhere near that in a general population sample. But yes, probably a combination of medical record studies, getting what we can from what's reported in conditions, in addition to or maybe using those medical record studies to then drive sampling procedures for more specific study of more specific groups. So that doesn't give you a comparison sample. I think one thing to think about too is that even though it's really helpful to think about comparison, and we do naturally do this comparison, the impact of experiences was so severe, it's in some ways not even necessary. I mean, it is necessary, but not even necessary. Oh, totally. Yeah.
particular aspects of the
Yes.
that would be really like the sensory component, for example.
Yeah.
Would be interesting. I think that, there might be things that are really similar, like both groups, if you were to survey activity developing for non-human population, might also report really high incidence of brain for
Yes. Yeah.
but may not report for the same type of sensory
Disabling or
some interest in comparison.
Yes. Totally agree. Yeah. And I think to answer those questions, my instinct would be medical record study to look at frequency, use data from that to then drive sampling. And then in terms of what was your second question again? Oh, right, a late diet. So concerns about the representativeness of the sample, given that it's a sample of late diagnosed. Given the intensity of the experiences, it makes me think, though I don't have any data to support this yet, that this is a pretty universal experience. I think once we start to think more broadly about the autistic population of those who were born with the female reproductive system, we need to be more creative in ways to assess all individuals. If there are individuals who are non-speaking and have no way to communicate, but are experiencing immense pain during their menstrual cycle, like we need to know that, right? So I don't suspect that there are going to be any differences, particularly since individuals are typically presenting more often when they have to medical providers, when they have more significant medical needs. I think with some individuals, it's just, we're going to need to be more creative about how we assess.
One thing that could be something to think about is sometimes people are getting diagnosed later, not always, but sometimes they're getting diagnosed later because of diagnostic confusion.
Yes.
They're getting diagnosed with other things instead.
Yes.
So if essentially you could have some confusion that people were more likely to have something with anxiety or depression or other things that may be diagnosed with one thing. And those other things.
Yes. Yeah. So I'm just saying what you're saying back. So it's like I'm doing great active listening, but it's, thinking about the misdiagnosis or that are happening prior to an autism diagnosis among the sample of individuals who are late diagnosed. I would say this is the experience of about 90% of those who are late diagnosed. The number of diagnoses they receive before an autism diagnosis, both physical health and mental health related, is exhaustive. It's like the entire DSM essentially. And then you arrive magically at an autism diagnosis that all of a sudden explains everything, right? So yes, I think there'd be something interesting there too in thinking about the experience of anybody who potentially has had any diagnosis, any mental health related diagnosis, thinking about autism symptoms and continuity. But, going back to the slide and thinking about the threshold of symptoms needed to experience, this is probably true across the general population. Somebody who's depressed but not autistic might all of a sudden become suicidally depressed during certain parts of their menstrual cycle. So this is probably true of all symptoms, not just related to autism in the entire population. We just don't have a good understanding of that, like you said. I know. So Shula, research for the rest of our lives. Yeah.
Right. And Sheila loves the sensory part too.
Yeah,
sure.
And then, here, Amanda.
Talk to you later. So
Okay, let me take one from so hi Alexandra, I'm an autistic woman working in the area of sexuality. I had a cervical biopsy done a few years ago and it was excruciating physically and mentally. How can we better prepare autistic women for gynecological procedures and better educate OBGYNs on the sensory needs of autistic patients?
Yeah, it's like solving the world's problems. And, thank you for sharing that experience because it just further highlights we're not just talking about menstruation. It's every aspect of women's reproductive health. And the process of going in to see the doctor is an overwhelming experience in so many ways, as you had highlighted. It's the sensory component of being on a medical exam table. It's being with an unfamiliar person who you aren't experiencing or talking with regularly. I think also there's an element of the subjective experience of every individual is so specific that we need to have a better idea of how to prepare certain individuals given their specific needs in different settings. So if you think about going into the doctor, to have a medical procedure, the doctors, this is particularly true in the area of reproductive health, will ask you what your judgment is. So you have this option and this option, which would you prefer? Right. And we're like, I don't know. I'm not a doctor. Like, I don't know. What are the side effects? Like, what is my experience going to be? Am I going to be anxious? Right. So in order to be able to make those decisions, you need the information the doctor has, and you also need information about yourself, and you need to triangulate those things. So brainstorming, I would say one thing to think about is to really lay out the range of experiences during specific medical procedures and layering that information and asking a person to talk about their specific needs and seeing how those things meet, and potentially having then conversations with medical providers where they're able to guide a patient through almost a decision-making process that is very personalized to the individual. And there are definitely ways to do this. I mean, it would be so simple to ask people on exit from different procedures, what was your experience? What was your pain level? Were you anxious? I mean, just very basic questions that could then drive some thinking around how we could better structure that process. And like you said, the medical providers, there just needs to be a more understanding and education. And I know, there's a part of being a physician where you do have to learn to detach a little bit. But how do you do that while also being sensitive to a patient's needs? So there's a component of that too, helping medical providers navigate that divide. So it's a complex issue.
I have more, but do we have more here? These are interesting.
There's one over.
Oh, let's take this one. Yeah.
I have a question. It sounds like that a lot of the participants that you interviewed, that they mentioned like endometriosis, for example. Was that like a question that you asked if a participant had a pre-existing like PCOS and endometriosis, PMDD? Like, was that something that you had asked, and how did that factor into your finding?
Yeah. So question was, did we ask about prior reproductive health related medical diagnoses? And we did. We had a survey question where we just listed very common reproductive health diagnoses. I haven't included that here, but there were many. Yeah.
Okay. So the question is, if the natal girls had received more information and better treatment over time and lack of suffering, do you think that would have impacted the choices the women made to have hysterectomies? Or is it the sensory experience and overload experience itself as the primary motivating factor?
Yeah, I don't know, because I can't speak to the individual experience, just from what the individuals had reported, that it typically was related. I think the driving factor was related to pain. And I don't think we know enough about pain management during menstruation or pain management during any reproductive health related, concern. So yeah, I don't know that I can speak to the question because it's not my experience, but given what the participants said, what was driving hysterectomy was predominantly pain. That resolved immediately following their surgery. Yeah.
Okay. Here's another interesting one. I'm just going to stay up here. Do you have any concerns about self-selecting bias in the people who took part in the research on the topic? And I'm not saying that this isn't incredibly important, but I do worry about whether we get more people volunteering to take part who have negative experiences. And what are your thoughts on this? And how can we be sure to,
Totally. I mean, there's more and more articles coming out about sampling and autism research, particularly with online surveys, which I really appreciate. Many of you know how much I love measurement and thinking about these issues. I think because of the frequency of women's health related concerns we saw in the prior study, which was just individuals recruited to talk about their eating and sensory experiences, that almost is triangulating for me. And then we have the additional history of healthcare surveys from other research groups where we have this extremely high rate of dysmenorrhea, like over 90% in autistic individuals. So we're triangulating across a few different sources, but we just need a lot more data. We want more data.
Yeah.
Yeah.
Okay. Were there a significant portion of participants who resorted to self-medicating and related self-research,
Mhm.
like using supplements or at-home
Yes.
solutions? Yeah,
Mhm.
because they didn't find adequate care or solutions from health providers. And then, for example, she wasn't able to find solutions for 2 of her issues
Mhm.
via prescribed medicine,
Yeah.
but found luck finding kind of solutions online
Yeah.
from other women.
Yeah.
And
Yes, thank you. Thank you for bringing up this theme, because this was also very prominent. People going, or participants just trying so many different solutions. And those also included alternative medicine. So the first example that's popping into my head was raspberry leaf tea. One person said raspberry leaf tea was the thing that worked for them in managing their pain during menstruation. So, and that was just one example. Different things popped up for different individuals. So when I'm thinking about, the discussion of personalization of treatment, like clearly there are different things that are working for different people. And it took people a very long time to arrive at treatment options that work for them. And often those were not prescribed options because they had been dismissed repeatedly by medical providers, or medical providers weren't able to figure out how to best treat the concerns. So yes, the answer is yes. And thank you for bringing that up as a theme, because it was very prominent. Yeah.
so maybe just one last question, and if you don't have one, I have one. Okay, I have one. So I'm about the self-selection,
Yeah.
and you did this an online survey through Zoom?
This one we just did survey. The prior one was interview Zoom.
So you don't actually know
Mm-mm.
if they were real people,
Yeah, yes, this is true.
right?
Like the bot issues you're kind of referencing.
Yeah.
Yeah.
It's a huge issue these days.
Yes, I think again, because of the triangulation with the prior study where we did interview everybody, we talked with everybody.
Mhm.
It was less, I didn't feel hugely concerned, given the responses that I had and how overlapping they were with what had emerged in the prior study. But I do think that this is the bot issue is a huge issue. We had done certain things to try and prevent bots where they needed to go through email with us. There was some degree of correspondence, then they got a survey. So there was some degree of bot control, which I can talk more about. But yes, I agree. Bots are a huge problem. And how do we conduct research on potentially a group of individuals who would prefer to just have like an online dialogue without the risk of it being
Who knew?
not a human.
Right. Okay. Well, I think our time is up. So thank you. That was great.
Thanks, everybody. Go change the world. Take this information. Yeah.